Hello everyone. We are beginning the webinar with CalMHSA and Rand, and Dr. Wayne Clark will provide background and insight.
Good afternoon. This is Wayne Clark. I'm the Director of Behavioral Health for Monterey County and the President of CalMHSA. My first challenge is, how do you introduce the Rand Corporation? Well, I will only introduce the colleagues that I know there and let you Google Rand for the history and other projects they're involved in. Dr. Audrey Burnham is a senior health scientist with Rand who is the lead researcher on the CalMHSA-funded evaluation of the statewide prevention project to reduce stigma, prevent suicides, and improve student mental health. The Rand proposal to do the evaluation was competitively bid in 2011 and awarded about a year ago. The competition was stiff, but the review panel unanimously agreed that Rand had the capacity and knowledge to evaluate a project of this size and scope. The CalMHSA has been very pleased with their progress to date, and they will describe it a bit as they present. Also last year, the OAC and CalMHSA agreed to expand the scope of the Rand contract to look at a framework for evaluating prevention programs in the state. Dr. Kathleen Watkins was the lead on that effort, and she is also on the webinar. Several counties, including Monterey, have been using the framework and logic model as presented today in an effort to more clearly define programs, measure impacts, and look toward accounting for treatment and prevention services provided in our communities. The logic model provides a simple template to have conversations with stakeholders, clients, family members, policymakers, and the media. I look forward to hearing Dr. Watkins and Dr. Burnham present the impact of prevention and early intervention on mental health in California's population. Audrey and Kathleen, it's yours. Catherine.
Hi, this is Kate Watkins, and I'm going to present the first part of this webinar and then turn it over to Audrey Burnham. And what we're going to talk with you today is, if you go to slide number 2, first I'm going to give you a little bit of background behind the development of the prevention and early intervention evaluation framework that we developed. Then I will actually show you the framework. There are actually several of them, so I will show you both of them and walk you through how to use them. And then I will turn it over to Audrey to talk about how this approach or this framework might inform the broader Department of Healthcare Services evaluation and accountability system. And it's our understanding that the Department of Healthcare Services has requested a design for a comprehensive evaluation and accountability system for California community mental health services. And the framework may be helpful as an approach in thinking about this. Lastly, we'll conclude with some recommendations for the PEI or the mental health, the MHSA components of the DHCS evaluation and accountability system. I'm on slide 3. So just to provide a little bit of background, the Mental Health Services Oversight and Accountability Commission, which is the body responsible for overseeing the Mental Health Services Act, which was funded through Proposition 63, coordinated with CalMHSA to develop a statewide evaluation framework. And this framework was supposed to be sort of an approach to think about the evaluation and monitoring of the public health or long-term impact of PEI funding on the population of California. And as Wayne mentioned, CalMHSA selected Rand to develop the framework. Slide number 4. Our task was to develop a strategic evaluation plan to look at the long-term impact of PEI funding. And like I mentioned earlier, our goal was really to look at the impact of the funding on the population of California. It was meant to provide a foundation that could be used by multiple levels of government to monitor performance, so that the state could use, counties could use, and individual programs could use to think about how collectively we were doing in terms of reducing the negative outcomes identified by the Mental Health Services Act. Those negative outcomes were suicide, homelessness, incarceration related to mental health, prolonged suffering, removal of children from the home, also related to mental health problems, unemployment, and school dropout. It's important to remember that even though the framework was to look at the mental health of California's population, an important part of the MHSA is to increase access to services for historically underserved populations. And so the framework also needed to be able to address the issue of equity and how we were doing at reaching specific populations who historically have been underserved. Next slide. I want to tell you a little bit about how we developed the framework. The most important thing is that we involve stakeholders at every step of the way. We conducted about 48 different interviews with key stakeholders. Some of these were technical subject matter experts, people who knew a lot about cultural competence or about, the jail system or the school system. We spoke with county and state administrators as well as consumers and family members to get their perspective as to what kind of framework would be the most useful and what were the important things the framework should be able to accomplish. We presented draft frameworks to a number of different committees and groups, including our statewide evaluation experts team, the CalMHSA board, and the Mental Health Services Oversight and Accountability and staff and evaluation subcommittee. We also took the framework, we ran a number of different county work group meetings in different parts of the state. And as part of those work group meetings, we presented the framework and got feedback from, if you will, on the ground people. And in response to all this feedback, we went ahead and revised our approach and have now completed it. Slide number 6. So the final report, which you don't have, which you can certainly look at, and we have for distribution, consists of the background to the project, more extensive detail on the methods, and the rationale for the way we developed the framework. It also discusses different analytic approaches and concludes with some key recommendations. The report is actually the shortest part. The technical report is the shortest part of the full report. The appendices are really where most of the meat are, and the appendices consist of the different frameworks that I will explain later, descriptions of the state-level databases, state or in some cases national level databases, which could be used to populate the frameworks. And there are 40, we've discovered or were able to come up with 41 different databases that are either national or in the state of California that could be used to look at the various outcomes that were enumerated by the Mental Health Services Act. Then we also have an appendix that looks at measure specifications for each key outcome and how you would actually go about measuring them. And lastly, we present a number of different statistical approaches towards analyzing that can be used to analyze the data. So that's what the final report consists of. Next, slide 7. So the vision behind the framework, and this is what we really heard over and over from the stakeholders, was that the framework needed to capture system transformation, that this was really, this investment in PEI funding was historic. And there needed to be a way, and it was really meant to transform the mental health system from a kind of fail first to identify people and get them help before they fail. So really turning the whole system around to get people early. So they wanted the frameworks needed to be able to capture and document that. Another key goal of the framework, as I mentioned earlier, was to monitor progress towards mental health equity. And lastly, the idea behind it was also that it could be used to help the Mental Health Services Oversight and Accountability Commission to fulfill their oversight responsibility. Next slide. Based on our work, we think that it is feasible and achievable to actually meet the vision. We think that it is feasible to evaluate the impact of the MHSA funding in real time without major new data collection efforts. I say MHSA rather than PEI because it turns out that it's actually very difficult to disentangle what is the impact of PEI specifically and what is the impact of the MHSA and the full service partnerships specifically. And in reality, the two were never meant to be seen separately. They were meant to be seen as part of a continuum of care. The frameworks, if they were implemented, would provide important information on what the current programs are doing and would be a basis to look at longer-term monitoring and see how things were changing over time. You know, changing mental health outcomes like suicide or unemployment or school dropout are going to be long-term outcomes. Those are not things that are going to happen overnight. And it's important to set up a monitoring system that can look at these changes over time. And to do that, you need a baseline. So implementing the framework and we really see that as the sort of one of the key conclusions is the importance of looking at whether or not you have the structural capability of providing the services you think you're providing to the populations that
I'm having difficulties over here. So do you want me to go to slide 9?
No, actually, I want you to go to slide 10 now.
Okay. Okay.
Okay. So as we created two different types of frameworks. One was the overall approach framework that really looked at a high conceptual level how one might think about the impact of PEI funding and looking at the steps between the funding and then eventually population health. And then in addition to this overall approach framework, we also created what we call outcome-specific frameworks. And there's a different one for each of the key negative outcomes, so suicide, homelessness, unemployment, school dropout, prolonged suffering. And these outcome-specific frameworks look at the, try to identify both the programs and the programmatic activities that should be logically linked to first short-term outcomes and then the long-term population health outcomes. And both types of frameworks look at or show the key components that we think need to be measured and tracked over time. Next slide. So in order to develop the framework, we used a very well-established approach called the Donabedian Model, which towards quality measurement. And we adapted this model for prevention and early intervention. And this model really says that when you're looking at quality and when you're looking at sort of evaluation, you need to think about 3 different boxes, which Donabedian calls structure, process, and outcome. And essentially, structure looks at the conditions under which care is provided. What are the physical resources that are available? What programs are available? What kind of staff is available? You know, is it a for-profit or a not-for-profit institution? Those would all be measures of structure. Process is really what happens, and that is both what happens in terms of treatment, so going from screening and diagnosis to treatment and rehabilitation, and also what kinds of activities are happening with respect to education and prevention. So you can think of process as what are the things that people actually get. So you have a program to reduce suicide. You know, do people actually call the hotline, for example? And lastly, Donabedian speaks about outcomes, and in his model, these are the changes that occur that are attributable to healthcare, and specifically to what happened in box number 2 in the process box. And those could be things like morbidity, mortality, quality of life. In the area of prevention and early intervention, it includes things like knowledge and attitudes and some behaviors, as well as patient experiences with care and satisfaction. I think it's important to, just in terms of language, to keep this in mind, because when we use the word outcomes, we're really referring to that 3rd box. But I think it's also possible to think of that there are structural outcomes and there are process level outcomes. So for example, if one of your goals is to bring care to a population that has previously been unserved and you build a new clinic in a particular area, you could call that's a change in structure, building this new clinic. And that is, you can think of that as a type of outcome. But in the Donabedian model, that would be considered a structural change rather than an outcome. Okay, this is the overall approach framework, if you will, and it starts with funding. And it's what this slide is really showing is start with funding, and you have a community planning process, and then the funding is supposed to do some things, and in that box we have it as the where is it going box. The next box is the what is it doing. So you've created some structures or you've funded some activities. The activities are actually happening, and then you have the short-term outcomes and the public health benefits. So if you're going back in more detail, the PEI funding was supposed to go for new and enhanced community resources, things like public awareness campaigns or parenting programs. It was supposed to go to new and enhanced treatment resources like first break early intervention programs or school-based mental health treatment. And then there were also collaborations and programs to increase collaboration and coordination among agencies, for example, primary care integration. So these were the sort of new programs or new activities that were funded as a result of the PEI funding and the community planning process. Then these new programs or resources were supposed to result in more and better prevention, more and better early intervention, and more collaboration and integration. So for example, you funded a social awareness, a public awareness campaign, And then in box 2, you would say, well, how many people actually were exposed to that public awareness campaign? Or how many people actually got parenting skills or used school-based counseling? Then that is supposed to result in changes in short-term outcomes. And in the area of PEI, we hoped that it would result in changes in knowledge, behaviors, and attitudes. And we also hoped it would result in increased resilience and emotional well-being. And that these changes in knowledge, behaviors, and attitudes, and in resilience and emotional well-being would then lead to the long-term public health benefits, reducing suicide, reducing prolonged suffering, and so forth. Now, PEI was not supposed to just intervene or make a difference for the people, in these 4 boxes. It was also supposed to affect the whole community. And so one of the things that the framework shows is that it's important also to look at whether the funding increased community supports and resources. Did it actually result in stronger communities? And there are measures of community resilience. And did it result in people accessing and using more private and public mental health treatment earlier? Was that part of that, was that an outcome of the funding? And then lastly, we know that all of these things are profoundly affected by the socioeconomic context. Okay, now I need to go on to the next slide. Now I'm going to show you an example of one of the specific outcome frameworks, and we chose suicide, but as I said, we've got one for each one. So again, you have PEI funding, and these are examples in box 1 are examples of where the funding has gone so far. So it's gone to increasing hotlines and warm lines. It's gone to more suicide prevention, training and education programs, more outreach and depression screening programs. So if you wanted, those would be things you would want to measure. In the what is it doing box, you would look to see whether or not, okay, you funded more hotlines. Were there more calls to hotlines? Were more people exposed to suicide awareness? Did more screening actually happen? And then you would want to look at, if you were thinking about using this framework as a measurement tool, you'd want to look at, did it make a difference? And in the case of suicide, you might ask, did people have more knowledge about suicide prevention and where to go for help? Was stigma decreased? Was psychological distress decreased? And then lastly, did suicide decrease? Now, I think this is a nice framework, but you also need to think about how you would actually use it in your evaluation, with your evaluation hat on. And that's shown on the 2 blue boxes at the bottom. And programs according to need, and need stratified by age, gender, language, etc. And what this is really saying is that what we think needs to happen is that you would look at, for an example, where are the needs for prevention? Maybe your community planning process identified that there is a real need for prevention for teenagers. Then you would want to look and see whether you had programs for teenagers, where those programs were located, languages, and where they were. And so it would be that kind of gap analysis that would be really informative. And again, on the other side, it's, I think, important to look at these outcomes So you'd want to look at, you wouldn't want to just see decrease in suicide. You'd want to see decrease in suicide among the particular groups that you had targeted. So if you, again, we know that suicide is really a big risk in older men, and so you might look and see, you might have targeted older men, and you'd want to look and see, well, and then you would look at these changes over time to see, to try to look at or monitor the impact of the funding. Okay, now I'm on slide 14. It is, what we were asked to do was to causally relate the impact of PEI funding on changes in outcomes. And what we came, after doing the work, what we came away with was that it is possible to evaluate the causal relationships. So to say, this outcomes, but that is very technically difficult. So there, and I've listed a couple there of different ways that you could go about doing it. That's not what we actually ended up recommending. We recommended, instead of trying to look at the causal relationships, of really looking at the associative relationships between funding activities and outcomes. And I think it's important to remember that you're going to have similar challenges when you are trying to evaluate the causal relationships between any mental health program activities and outcomes, so not just PEI. Now I'm on slide 15. So the questions that I think the statewide evaluation framework can answer are the following. First of all, I think it can tell you, what did the funding achieve? What did we get as a result of this historic new funding? I think it can also help answer the question of, are we actually putting into place the types of programs that we wanted to? And the community planning, there was an extensive community planning process that identified populations that were in need. And so I think there's still gaps. Looking at outcomes by gender and ethnicity and age and language, those things can help us address the question of, is mental health equity increasing, especially if you're looking at changes in these outcomes over time. And then lastly, I think the framework can address the issue of how California compares to the nation and how counties compare to each other. I mean, I think that's complicated, but it is, you could look at and say, this county has a lot of this kind of program and very little of that kind of program, whereas in another county, it's the reverse. And that, again, opens up the possibility for a dialogue about, is this what we want? You know, is this what we intended? I'm going to pause here and ask and see if there are any questions that people have about what we've spoken about, what I've talked about so far.
A few people, and if you all have any questions, please let me know. Lily, do you have a question?
I do. I have a couple of observations. I know on the drug and alcohol side, we've had for a number of years the requirement that 20% of the federal block grant had to be dedicated to primary prevention. And all of the counties have taken taken those funds, and there are 6 strategies that the federal government defines as primary prevention. Recently, maybe about 2 or 3 years ago, we asked the state to run the data related to that. Data was telling us that we couldn't say anything that we had 1 million points of light, but we had no stories. And one of the reasons was because there was not any kind of direction at the state level on where to set priorities and how to spend the prevention dollars. So was there any conversation about whether or not, are you just, do you, for the MHSA PE, spend it on any one of these populations doing, you know, we want you to do these kinds of things, but there really hasn't been like 1 or 2 priority areas? Because I'm afraid that you're gonna collect information, lots of information, and what you will find is that you cannot say much.
I can take a shot at that. There definitely are some strategic priorities within the prevention and early intervention. But one of the things that our framework does is it recognizes that many of the longer-term kind of downstream outcomes that are ultimately of interest are they're very distal. So they're distal in time. They often aren't directly affected by the prevention programs, but may be secondary effects, like you know, a prevention program may influence an individual who influences somebody else, or has a broader kind of community impact. So in fact, it's very difficult to really move some of these larger indicators, for example, like suicide rates, because they're fairly rare. It takes a sustained kind of long-term effort to begin to see change in some of these broader societal outcomes that we really care about. And so this PEI are the more direct kind of proximal outcomes that these programs are actually trying to influence. So changes in knowledge and attitudes and behavior, and sometimes changes in well-being or in symptoms are really the direct outcomes. And there's a lot that can be learned by looking to see whether your services are having the impacts that are expected on those short-term outcomes, because you really need to see that effect before you're going to see any of these more cumulative long-term effects on some of the downstream indicators.
Have you, in your search, have you found what would constitute critical mass, and at what point do you see the tipping? Where the tipping point is, where you begin to affect change?
Have launched, where you actually have a pretty comprehensive long-term set of programs. And so we can look at those and get a sense of what it takes to get some of the program effects. but that's an area where there's not as much known as we would like to know. And in the substance abuse prevention arena, I think there's also some pretty good examples of kind of what it takes to make some changes at the community level that might be helpful in helping you think about what the services and length of time of those interventions might be before you see effects.
Right. I know that the Partnership for Drug-Free America, for example, they were the sponsors of many of those public awareness campaigns, those mass media campaigns. I'm thinking that there has to be some kind of information that tells them, certainly from a marketing perspective, you know, how many times does somebody need to see your message before you're going to see an effect? So in some ways we might want to borrow also from other fields, other disciplines, other places. And I would think marketing would be.
Right.
Did that answer your question enough?
Lily?
Yes?
Did that answer your question?
Oh, yeah.
Great. So I guess other questions? If not, maybe keep going then, Kate and Audrey?
Okay, sorry, I was muted. This is Audrey Burnham, and I'll take over the briefing now. So what I'm going to turn to now is a few thoughts that we've had about how a framework that something like this PEI evaluation framework might inform the broader DHCS evaluation and accountability system planning. And these are really just preliminary thoughts because we've mostly spent our time thinking about prevention and early intervention framework within the context of the Mental Health Services Act. So let's move on to the next slide, 17. And this is, again, the structure, process, outcomes model. And this is a little bit of our thinking about how this framework might inform a substance abuse and mental health. And this model includes not only structure, process, and outcomes, but it starts with, as our earlier models did it starts about thinking about, well, what is the funding and policy and sort of regulatory environment within which these services are being implemented and delivered. And then what is the structure of the what difference does it make at an individual level, and then finally what is the broader impact beyond individuals that actually come into contact with the services on society, and various benefits and costs that might be associated with these services. And this model, you can think of it as a production function, so it's a logical model, and it's the way that you might think of how policy and financing influences the implementation and delivery of services, which in turn can influence individuals and broader social goals. So this is a very broad framework, and measuring the important things in these boxes, in each of these boxes, and establishing the links, say the causal links between the boxes, it pretty much defines the field of health policy and services research. So this is a very comprehensive model and a very flexible model. And so the thing that I was trying to think about, and the question is, in my mind, is how would you evaluation and accountability system? And there are a lot of different things that can get packed into the words evaluation and accountability and outcomes and performance. And just reflecting on this model, you can perhaps appreciate the fact that you can have evaluative and decision support information within each of these boxes. So for example, you know, at the policy level, you may have evaluative information to kind of ensure regulatory and fiscal compliance. At the structural level, you may have evaluative information to figure out how well programs are meeting recognized standards, for example, of facility licensing standards, staff credentialing requirements, training and certification, and best practices. At the process level, you can have evaluative information that includes things like the ease of access, cultural language and language appropriateness indicators, clinical appropriateness indicators, so that you would know something about overuse and underuse of services. You could consider cost efficiency at the process level and quality of care measures as well. At the outcomes level, for individuals receiving services, we can be thinking about how services are related to improvements in health and quality of life. And this box also recognizes the fact the actors and decision makers in promoting their own health or their family's health. And so their satisfaction and engagement and participation in care is an important outcome for evaluation. And then we can also think about the broader societal outcomes and how, with the Mental Health Services Act, for example, issues of equity are key policy concerns, and also members of society and to avoid some of the negative consequences of mental illness. So those are all important social benefits. So this is a very broad and comprehensive model, and how you approach thinking about planning and evaluation and accountability system for Department of Healthcare Services depends on your evaluation objectives or purposes. And let me talk about what some of those might be. So go to the next slide. Thank you. So one of the purposes of an evaluation and accountability system might be individual care management. And these systems can be particularly important for individuals with severe and persistent or complex health issues. And things like consumer-centered decision-making, team models, where you have team models of care, where there may be some need for cross-agency collaboration, for example, collaboration between mental health and substance abuse agencies, or mental health primary care, and coordination across agencies or among team members. And there are a lot of different approaches to developing these systems. Typically, the centerpiece, the infrastructure to these systems involves some kind of registry that may be electronic. It may be electronic health information registry. And it allows better coordination of care. It may include things like reminders and feedback to caregivers or to consumers. And that can be a really important system capability to help in individual care management and ultimately. Next slide. Another purpose of an evaluation and accountability system could be provider organization performance and performance improvement. So we can think about a community-based provider, for example, that wants a system to be able to routinely monitor aspects of care and evaluate the quality of the care that's being provided and to make improvements in that care. And typically these systems are very specific to that organization's goals and objectives, and may even differ within programs within an organization. So often the kinds of things that that system can address are things like to the target populations of the program. Adherence to best practices may be some part of the evaluative system for that particular objective. And in addition, it may be important to be able to monitor client level or individual results, outcomes, things like program completion, satisfaction with services, improvements in symptoms, side effects, quality of life. Has been doing, for example, on palliative measures, seems to directly relate to this particular objective or purpose of an evaluation and accountability system. And these kinds of systems can they can support continuous quality improvement approaches, where what you're doing is you're planning, you're implementing, you're getting feedback about how that works. Then maybe you're making some changes, and you look to see how those changes are influencing your indicators to see if you're going in the right direction. So it's a great kind of approach for program support and organizational improvement. Another function could be to evaluate the effectiveness of a specific program or intervention. And typically, when you're trying to evaluate effectiveness, you need, I wouldn't say typically, probably all the time, you need two kind of conditions. And one condition is that you need a population, because the effectiveness studies are really only useful as information to your implementation of service delivery if you can define what it is that you're studying. So you want to be able to have a defined program that if in fact you find that it's effective, that program can be replicated in other places. The other really important thing about effectiveness evaluation is that effectiveness is always relative to some comparison situation. So it might be effectiveness, how effective is this program relative to no services, or how effective is this program relative to usual care services, or perhaps how effective is it relative, how effective is a new intervention relative to something older that's more tried and true. And effectiveness studies are particularly important in areas where we have promising or innovative to replicate, but we don't really understand yet how effective those programs are, and so we really want to gather that kind of information before we more broadly disseminate a particular program. Just one other thing about effectiveness studies is that seldom can we really evaluate program effectiveness only with information that supports program measurement, and that's because we usually need additional design rigor in order to evaluate effectiveness, and what we would have in a situation where we're routinely collecting outcomes information for the purposes of improving program performance or for the purposes of individual care management. So, next slide. And finally, the purpose could be of evaluation could be system performance. And there are some unique questions that are often asked from a system perspective. The most frequent demand for system performance evaluation and accountability is fiscal and regulatory management. So most systems in the public sector, for example, do a pretty good job of collecting information on service units, encounters for purposes of reimbursement or other kinds of financing mechanisms, and do a pretty good job of making sure that programs that have certain eligibility requirements for program participants are met. And so those other questions that really can be asked at the system level that are also important. And some of these could be taking a look at the broader questions that relate to how services are delivered across the population, and is there the right mix and quantity of services, availability of services relative to population needs. This is an area where the question of disparities, is there equity in access to appropriate services across different regions, across urban and rural populations, across different ethnic groups, language groups. At the system level, you may also have a need to evaluate various policy and planning choices. For example, there are a lot of new opportunities with the Accountable Care Act to expand Medicaid, various provisions that could be adopted, and it might be important to conduct evaluation and to have systems that would allow you to evaluate what the impacts of various choices you might want to do is you might want to track key healthcare performance and quality indicators. So these aren't all the questions that you might want to ask at a system level, but some of the key areas that came first to my mind. So one of the things that can be really useful at the system level that can help you determine what population needs are and to look at how your user population or those individuals who are getting services relate to broader population needs and disparities. Okay, next slide. So these different evaluation and accountability objectives the things that is important to think about is to think about what are the evaluation objectives of this broader comprehensive plan, and to what extent does that plan really want to focus on individual care management, provider organization performance, really important, but I think it's a really Herculean task to try and do all of them at once. And in my view, it's pretty much impossible to ask that system-wide data serve all of the objectives of these other objectives: individual care, provider performance improvement, and program effectiveness. And that's because the sheer quantity of data, the need for tailoring at the level, say, of the program and the individual that's needed to serve all of these functions, the standardization requirements at the system level, the design and analysis requirements to really understand program effectiveness, that these are just too burdensome and too much to ask of a system-wide accountability and evaluation framework. I think that another developed for other purposes. For example, if data have been developed for individual care management and for program performance improvement, that this data can be rolled up and contribute to system-wide evaluation. But given the burden of data collection and standardization requirements to achieve roll-up and have reliable and valid measures at the system level requires, I think, that you be really strategic and selective in what you decide to roll up to the system level from these other levels of evaluation. So at the system level, one strategy might be to start with the low-hanging fruit. So establish important priorities for looking at system performance and accountability, and find ways that existing data can be used and perhaps leveraged or improved to address some of these priorities, and then establish addressing those evaluation priorities can be developed. And that's what we did in thinking about the Prevention and Early Intervention Mental Health Services Act framework, is we were really thinking of this framework as being a framework at a systems-wide level that would be looking at some really important evaluative issues for system performance. And so we made some next slide, please. So yes. So now I'm moving to those recommendations, and these are recommendations that are within the context of thinking about the Mental Health Services Act, but they might be the sort of strategy that you could think about for a broader system as well. So one of our recommendations was to use and strengthen existing data. Is the lead author on. She reviewed lots of existing data sets that were available to measure many of the shorter term and longer term outcomes in those frameworks. And these were data sets that, they have various strengths and limitations, but they're, for the most part, they're ongoing data that can be accessed to track these outcomes. To include key measurement of key aspects of not only outcomes but structure and process as well. So there were recommendations to develop more data to be able to describe PEI services and who they were reaching. There are issues to consider with using existing data and how to link different data sets. There could be a lot of additional analytic capability with linking available data sets that now are separate. So an example of this might be, better linkage between criminal justice data and mental health data. We also concluded that in some cases, existing data could be improved. For example, there are various ways that state suicide data could be improved. There's an existing California Healthy Kids survey where better mental health information could be collected, and so there are existing data sets that might be built upon. Okay, next slide. Slide 24.
It's refreshing. Here we go.
So in the prevention and early intervention area, there currently is no standardized information that can roll up to the broader county and state levels about what kinds of PEI services are being implemented and who those services are reaching. So we recommended to develop standardized measures, and that these measures should be fairly core, fairly not extremely detailed, but really just get the necessary information to be able to describe the specific programs funded, their target population, and who was reached by those various programs. And that over time, other information could be developed that might provide broader descriptive information about one of the things that the framework could do is provide information about the quality of services that are provided. This would be kind of within that process box, so not only knowing who is reached by various services, but what the quality of those services are. And there are a lot of examples of quality of care measures that have been used in the and some of these could be developed and thought of as important evaluative components in the for the Mental Health Services Act system, as well as for a broader system. And however, there are lots of different things that we need to think about, and before selecting and implementing these measures, there's a lot of existing experience that can be looked to, and in some cases there may be new measures of interest, but those new measures should be evaluated, they should be piloted to really establish their feasibility, their relevance, their reliability and validity, the cost of collecting them, et cetera. Next chart. Another thing that we think is important at the system level is to develop user-friendly ways to display information at the systems level so that people can understand it easily, interpret it easily, and one approach to doing this is to, as part of the system, to really develop digital dashboards with the capacity to deliver information tailored to different needs of users. And you can think about these dashboards as being figures that report on information that allows the user to delve down into different layers of detail or look at information in different ways. The analysis essentially gets built into the reporting system so that it becomes a way to kind of routinely analyze and report in an ongoing way on information that's collected in a consistent way over time. And next slide. One of the areas of great interest to CalMHSA and the MHOAC is the cultural appropriateness and cultural competence of PEI and other MHSA services. And that's an area where we were unable to find existing data or existing measures that might be used at a systems level. So this was an area where we recommended that there might be an area for further research and investment in developing standards and indicators and measures that might feed into program performance improvement objectives, as well as system level tracking objectives. Next slide. With respect to program effectiveness, we concluded that there are a lot of opportunities to strengthen the existing evidence base in some areas of services for prevention and early intervention. Program partners that we're familiar with are implementing programs that are already evidence-based. So the approach there is really to look more at their adherence to practices that there's already an established evidence base for, that are already established as effective. But in other cases, programs are being, there are innovative programs, or programs are being adapted to serve different populations than they were originally designed for, like different cultural groups. And so there are some innovations going on that are potentially really important, and that could be really good targets of focused program effectiveness studies. So we did recommend in our report that that there be consideration of conducting rigorous evaluations of strategically selected promising programs, but we did not recommend attempting to determine comparative effectiveness of different programs using routine monitoring of outcomes that might be done as part of, say, program improvement or individual care management. And we've come to the end, so I'll stop here for any questions.
Well, is that possible?
Kate, do you want to be there? I could answer that too. It's not, we do, I don't think that maybe in some instances new data wouldn't need to be collected because there are a lot of existing data that could be tapped to serve a lot of purposes. But I don't think we believe that there's no new data that would be needed. So in the area where we know most, which is based on our look into data available for prevention and early intervention and kind of populating data into the domains of interest, there were a lot of data that was already available and could be utilized, especially looking at population level outcomes, both short-term outcomes and longer-term outcomes. But there was new data needed in that there's currently really no data available on in the structure and the process box. So developing ways to describe what PEI services are being implemented and where, and kind of what their programmatic resources and activities are, and developing ways to describe who's using those services or who those services are reaching would be very important areas of new information to develop.
Yeah, and to me that gets to the point that Lily was raising about the 1,000 points of light that they had with substance abuse, and they weren't, or substance use prevention, and they wasn't able to really categorize that. But what I'm seeing from the framework and the logic model is that you're indeed sort of creating categories and constellations of prevention efforts and being able to better describe those. And I think that's a significant improvement on what we currently have. The question I have with that is how can that be aggregated statewide? I think in some ways you say it can't, but that's one of the concerns I think people statewide. If you're taking prevention efforts in Modoc County and Los Angeles County, are you going to be able to categorize them similarly according to health, education, crisis lines, that kind of stuff?
Right, and currently that's not available. So I think that's a big question about, you know, how important is it to really roll up some of this information, maybe at the simplest kind of description to the broader state level, or how much to really retain at a local level and not roll up.
So Lily has a question.
Oh, great. Lily?
I do. First of all, thank you so much for presenting. I have to say how much I really appreciate the framework that you've presented. And I think that the framework is broad enough to embrace not only alcohol and drug and mental health, but also treatment and prevention. So the framework is really, it's very classic. Couple of questions, comments. So, for example, and let me tell you what I also appreciated. I really appreciated the acknowledgement that there is going to have to be standardization for us to be able to collect information, but also you're sensitive to the burden of collecting information. So I have to say I really appreciated that. On the drug and alcohol side, I know that according to the state, in our county contracts, we're required to use the strategic planning framework that was developed by the Institute of Medicine. It would certainly be worth it to know whether or not that was a choice that the state of California made, or it was a mandate that we have to follow as a result of the federal block grant. So it would be a shame to have two frameworks. I think that counties, you know, using one framework, and like I said, I really appreciated the Rand, you know, the framework that you presented. So that's a question that I'd sure like to get an answer to, as to whether or not there's any leeway on that. And then I think out of process, Wayne, I was wanting to know whether or not, because it's absolutely true that you have to articulate what the evaluation objectives are before you can start planning that process. And I was just wondering whether or not, is it going to be within the purview of the business plan that we're working on, that we're going to be able to make recommendations about that or not? Just wanted to know. And if maybe you don't know, but I just thought I'd
well, let me handle that, and then Audrey and Kate can talk. But yeah, the recommendations are going to go through a process, and I think there'll be another draft sometime in the next week or two. Then there'll be a full meeting in I think the week before Christmas, and then there'll be a larger, even stakeholder meeting early in January. So there'll be opportunities to comment and improve and make recommendations.